Welcome once again into the Radiopaedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, some people have labelled him a bit of dependent sludge. It's my co-host, Frank Gaylord.
I have a feeling these intros are getting meaner and meaner, Dixon.
I think that might be the case. No, a bit of sludge never hurt anyone, Gaylord. It's a term of endearment anyway, isn't it? Sludge. Have you recovered from your big day out on the weekend?
Yes, very much so. For our dear listeners, I went to a one-day music festival last weekend with my gorgeous wife, Natalie. It was part of the Red Hot Summer Tour, which, if you know anything about Melbourne weather, was anything but hot. And it was a bunch of old Australian bands headlined by Crowded House. Yes, I know if there's any New Zealand people, are they people in New Zealand? Yes.
Sheep, I think. Sheeple?
If there are any New Zealanders, they'll claim that Crowded House was a New Zealand band. But anyway, the Waifs were there, Mark Seymour from Hunters and Collectors, and The Church, and Angus and Julia Stone. And it was good fun.
Did you have to stand up for the whole list thing?
I did. It was, no, you didn't have to. We took a couple of deck chairs because it was at the Mornington Racecourse.
Yeah.
And there were a few
I thought you were going to
thousand
say you
people
took
there.
a couple of and then insert party drug name.
No, so we had a couple of deck chairs to retire to, but we actually spent almost the whole time in the mosh pit down the very front, which was pretty good. And if you're picturing a mosh pit with brawls and stage diving, well, this is a different kind of mosh pit because mostly, let's say Natalie and I were probably amongst the youngest 10% of the audience there.
Oh, really?
We were pushing our way past Zimmer frames and people with those canes with the little tennis balls on the feet. And it was such a white audience. It was unbelievable. So of the 2,000 people there, if you exclude the people selling sushi in the van or the people that are helping the attendants, I reckon Natalie was one of 4 non-white people in the audience. It was bizarre coming from Melbourne. But I guess if you stop and think about the age and the audience and the fact that it was in Mornington, it's not that bizarre. Really.
I can relate to both of those, the age thing and the racial demographics. I often go to like comedy shows and it may be a brown performer or an Asian performer, and then you look around the room and it's all white people. The audience is all white people for some reason. And then the other thing yesterday, so in terms of age, I was in the reporting room and for some reason I referenced that old Victoria Bitter beer commercial from many decades ago.
That's a great commercial.
Oh, it's a great commercial,
A big hard thirst needs a big cold beer, and the best cold beer is Vic.
Vic Bitter. Yeah, absolutely. Yeah. And the registrars and the fellow are just giving me absolute crickets. They've got no idea.
It's got the line, you can get it milking a cow.
That is what I was doing.
I've got it now.
I got it now. And I did all that, but I was doing the riff about something else, but I was doing it in that style and they had no idea, no appreciation. I've also got this registrar named Dr. Quinn and I call her medicine woman.
Yes, of course.
She's aware of why I call her medicine woman, but everybody else, all of the registrars and fellows, they have no idea who Dr. Quinn medicine woman is, and they just stare at me blankly like, who is this old man?
Like a dog that's been shown a card trick.
That's all right. Now, speaking of mosh pit, sludge, Gaylord, today's main segment is all about a place where the sludge loves to live, and that's the gallbladder, the biliary system, and there's a little bit of pancreas thrown into this main segment as well. So this was recorded at Radiopaedia 2025 earlier this year, and it features Joe Mullineux, Katy, Hickman, and Ed Godfrey. So that's what we're about to listen into.
That's great, but before we do that, a quick public service announcement, is that what they're called? Every December, we run our supporter drive where we try and encourage you to become a paid supporter of Radiopaedia. And the best thing about being a supporter, other than those warm and fuzzy feelings you get for supporting something that you care about, is that you get to experience the site without any ads, which is so much better. Every time I get to the site and I'm not logged in and I see the ads, I like, yuck, and I log in immediately. So don't get me wrong. I know the ads are rubbish. I know they make the site look crowded, ugly, and harder to use. But unfortunately, they're a necessary evil at the moment, and without them, we couldn't pay the bills. Without them, Radiopaedia wouldn't exist. So, for the foreseeable future, we're going to have to continue to show ads, but you, dear listener, do not have to see them. If you become a supporter by visiting radiopaedia.org/supporters and sign up now, it's a work expense, or maybe you can claim it on CME as a deduction, or maybe you can get your granny to gift it to you for Christmas. Who knows? It would really help us out. It makes it a lot easier to know that we have a steady income to plan ahead without the vagaries of advertising.
And don't forget, if you sign up for annual supporter billing, I think you go in the draw to win registration to the Radiopaedia 2026 virtual conference, which is coming up in July next year. So an extra incentive to sign up during the month of December. Let's get into the main segment, Gaylard. So this appeared in a session where Joe had just given a lecture on gallbladder diseases, Katy a lecture on primary sclerosing cholangitis, and you'll hear them refer to PSC throughout this talk, and Ed a lecture on pancreatitis imaging and intervention. So let's listen in, and then Gaylard and I will be back with our Zimmer frames to chat in the outro.
I'm now joined by Katy and Ed to have a chat about some of the trickier aspects of pancreatico-biliary imaging and intervention. I couldn't really have two better guests to talk about this. Both Katy and Ed are experts in the area, both working in Busy Centre in Cambridge, UK. Katy, I'm going to start with you. Your talk was fantastic. Thank you very much.
Thanks.
One thing I often think about is you talked about giving contrast. Do you do that for all your new patients when they come with a clinical question that even mentions PSC in the history?
Yeah, thanks for that question, Joe. It's actually quite a new change for us to introduce contrast liver with our MRCP sequences. So that really came about following that 2021 reporting standards paper that I included a QR code to if people want to have a further look, which says as part of the sort of essential sequences actually to use contrast. And I think what I've found is that it's helpful. One, it can rescue poor quality MRCP, so the delayed phase, you get a really good look at the bile ducts for any strictures. Also, if there's sort of cholangitis or inflammation. And then that big question of if there's a cancer there, we know that almost a third of patients will have a cholangiocarcinoma there in their presentation of PSC. So I've found the addition of contrast quite helpful.
Can I ask you a controversial question, Katy? What do you think we should do for surveillance of PSC?
So we've debated this a bit, haven't we, in Cambridge, Ed, and I think it really is a tricky one, and an area that needs a lot more research into how we survey these patients with PSC. That's borne out by the really varied approach around the world. So, which is probably due to the treatment options that are available if someone does develop a cancer with PSC. But in Cambridge, what we do is to be guided clinically. So after the baseline images, if there's a sudden stepwise change in the symptoms, so jaundice or itching, or if there's a biochemical stepwise deterioration, or if the CA19.9 jumps significantly, then we'd only repeat the MRI imaging at that point. Having said that, we do ultrasound surveillance annually, but that's specifically to look at the gallbladder. That really isn't to look for the bile duct changes, and that's in line with the UK BSG guidance. But I know if you were to go to America or even in Europe, their guidelines would suggest annual MR surveillance. But with the caveat in those documents that actually there's not too much evidence for either approach. So yeah, definitely an area for more research there.
Yeah, I think the one paper I was aware of from the Karolinska, where they did a prospective study of MR in this cohort, the only patient who they were able to identify as having cholangiocarcinoma and then get long-term survival for was the one patient where it was discovered incidentally at explant for transplant. So right. All the ones that they picked up in the prospective surveillance didn't actually help the patient survive any longer, unfortunately. So yeah, I think we'll stick with our ultrasound approach if that's okay.
That's interesting because I do get that feeling as I'm reporting these annual scans that I don't think I've ever found anything. So I didn't know that was actually borne out in the evidence as well. So that's really useful. With the sort of younger cohort we're dealing with PSC, Katy, do you think either you or the patients themselves worry about having lots of scans with contrast? And do they worry about gadolinium deposition? Or is that not really an issue?
from my opinion, I think if I have PSC, given the high rates of malignancy, so up to 10 to 20% of patients with PSC are going to develop a HPV malignancy, that risk for me feels greater than the sort of theoretical risks of gadolinium. But definitely there might need to be some educational patient choice around that.
I totally agree. And I think that's really a good way of selling it to if anyone who was worried about it, and just give them the hard figures.
Yeah, I think so. Unfortunately, this concern about gadolinium deposition seems to come and go in waves, according to how recently it's featured in the Daily Mail. So also that's a UK paper, by the way. Yeah, I think I haven't been asked about that particular question by a patient for about a year now. So hopefully it's dying down again.
Just going back to that periductal infiltrating cholangiocarcinoma. Now that is particularly hard to spot, and you showed that in your case, your cases. If you suspect this clinically and the MRI is equivocal, would you do both a contrast enhanced CT and a PET CT? How would you approach it?
So yes, these cases are often coming through the MDT causing headaches, and we throw the book at them. So they have a quad phase liver CT. If they haven't already had it, then they'll have the contrast liver with MRCP sequences. If you're still struggling, maybe throw in a PET scan there, as you say, but knowing that active inflammation is also going to be PET avid, so you could have some false negatives and also some false positives there. If you're still not sure, enroll the ERCPs, maybe do a spyglass as well. I think these cases, for me, and that's what I thought when I was putting this talk together, I was like, why am I doing the thing that I find the hardest here to try and explain? But I think these cases are really, really tricky, as you say.
Yeah, and do you use hepatobiliary phase contrast agent for all of these as standard, or do they tend to get just normal contrast, Gadavist?
So we tend to do the extracellular contrast agent, so Gadavist for these, but I think that's maybe more a local preference. We tend to find that there's less motion artifact with the Gadavist. You don't get that sort of respiratory that can ruin the hepatobiliary phase, and actually the delayed phase is really quite. I really like it for looking at those strictures. But I think if you were to say let's do a hepatobiliary phase, that would also be a good plan as well. I don't know what you think, Ed. Whether you have a preference for one of those two.
I agree with what we do. Because I think you're right about the respiratory motion artifacts. A big plus, isn't it, for using just standard extracellular contrast? And one of the things that we're trying to do is, some of these patients will be cirrhotic and at risk of developing HCC as well, and that's so we like extracellular contrast agent for HCC as well in Cambridge. So, but I wouldn't criticise someone for using hepatobiliary specific contrast medium for this. I think that's probably fine, isn't it?
I tend to prefer extracellular as well, but it's just sometimes with those masses in the liver, you think, oh, it would be nice to have that hepatobiliary phase as well, but we can't have everything, I suppose. In these cases, you've got to have some sort of trade-off. I really like how both mine and your talks, Katy, really enforce the power of ultrasound when assessing the gallbladder. You've already mentioned that you use ultrasound to look at PSC patients in detail, mainly looking for gallbladder polyps. I suspect some would find it quite attractive to streamline services and just do one test. How would you feel about the gallbladder assessment on MRCP?
So interesting you mentioned that, Joe, because I think some of the Italian transplant centres that have actually gone for 6-monthly surveillance MR, they have taken out the ultrasound surveillance, so they're just using the MR to look at the gallbladder. But as you've shown in your talk, and I think I agree with you that the ultrasound is king when it comes to looking at the gallbladder, and sometimes with MR it can be tricky to distinguish small polyps from stones, and trying to see whether there's enhancement in something that's sub-centimetre can be difficult.
Couldn't agree more with that. That's ultrasound is king, isn't it, for the gallbladder? What about right upper quadrant pain, though? Do you think we should go for ultrasound or CT first in patients with acute right upper quadrant pain?
Difficult one. I think for me, it really does depend on the patient and the clinical presentation. I am very much love the ultrasound first approach, so I would probably be pumping for that mainly. But if, say, you've got a really sick patient or an older demographic, they're in a ED, It's an easier test to get, and you can get a lot of information. I don't mind going straight for CT in some cases. But yeah, ultrasound's still king, I think, for right upper quadrant pain. There's lots of times I look at a CT and go, I really wish I had an ultrasound first, because then I'd be able to answer the question a lot clearer, I think.
Yeah, I think I completely agree with you, Joe. We sometimes make cholecystitis more difficult on CT. You showed how important the gallbladder distension was, and I think I find that easier with ultrasound. And you can also check where it's most painful for the patient, whether they're sort of Murphy's positive, and also get a bit of a history as well at the same time.
We often seem to find that patients get a CT first in our hospital, though, don't we? Which is annoying. So I'm glad you have the same experience, Joe. I think it's a bit of a constant battle, isn't it? But fortunately, you can usually get the answer with either test. But I think the resistance is least to go straight for CT, isn't it, for most patients? And I think CT is better for alternative diagnoses, isn't it, if it's not acute cholecystitis? So you can try and console yourself with that fact when they will go straight to CT.
Joe, I was just wondering, we're talking about cholecystitis, but often there's quite an overlap in imaging appearances between gallbladder cancer and these inflammatory conditions. And I was wondering what you do when you see some gallbladder wall thickening, and there's maybe not the extensive local invasion that we saw in some of your cases, but how often would you in the MDT recommend proceeding with, say, a radical cholecystectomy if there's diagnostic uncertainty? Or do you find that with enough imaging and biopsy, you can often unpick those two?
We do get those questions a lot. And I tend to just ask the surgeon or whoever may have seen the patient, often not, if they have symptoms attributable to the gallbladder, why not just take the gallbladder out? And most surgeons actually like that approach, because most surgeons like operating. So they will be, yes, I will take that out. But obviously you've got those cases where it may be a bit more equivocal in the clinical history, or the patient really isn't fit even for a laparoscopic cholecystectomy. And at that point, I don't mind doing further imaging, or even go on to do a biopsy if you've got a big enough mass to hit, just to get in the diagnosis. And generally we would go for an MRI initially, just to have a look, see if there's an enhancement. I am intrigued by contrast enhanced ultrasound, which is a great point of care test. You could answer some of these questions fairly quickly, but I must admit I'm not using that routinely myself for assessing gallbladder. I don't know about you guys. What do you think?
I really like it for gallbladder. It's great. I've got a few cases where it's been instrumental in distinguishing tumor-factive sludge from cancer. And it can also help you pick up that subtle thickening you get under early cancers, where the mucosa is thickened and just spreads out from the base of a polyp. So sometimes that's easier to see on contrast enhanced ultrasound. So yeah, I recommend giving it a go. It's a piece of cake. You can always ignore the result if you're not quite sure what it means.
Yeah, I think you can get some really nice high resolution images, can't you, if you've got a good window? So yeah, I will begin to use that. I do like contrast, but I just haven't yet used it in the gallbladder.
So Joe, I was going to ask you, as we changed our gallbladder polyp surveillance guidelines, and it provoked a certain amount of anxiety amongst the surgeons that we might be missing cancers, potential cancers. Did you have any resistance when you relaxed your surveillance?
Well, in my previous trust, so I've recently moved trusts. My previous trust, we actually did it collaboratively with the surgeons. They were quite keen to reduce the surveillance they were doing, and actually felt a lot of these were coming through the MDT that didn't need to come through the MDT. We worked together and we kind of made our own guidance, which was a halfway house between sort of the European and the American guidance, and what we thought was practical for our population. I've moved trust now, and we're actually using the European guidance. What do you guys use in Cambridge? Is it the European, or is it?
It's a sort of slightly diluted version of the European guidelines. So I've diluted it as much as possible. We're going to start taking on board some of the American guidelines strong points about, sort of focusing in on polyps with specifically benign morphology. If they've got comet tail artifacts and things like that, then I know the approach in Leicester, if you see that, is to describe it as a fatty deposit rather than a polyp, which I really like. I'm going to be stealing that.
So, Katy, you showed us some great cases of cholangiopathy mimicking PSC, immune checkpoint inhibitors, ketamine, cholangiopathy. These are things that weren't previously on my differentials. The other main group I can think of is infective and parasitic causes, so recurrent pyogenic cholangitis. Now, I think these are quite uncommon in Cambridgeshire. Some other international viewers might see them more often. Particularly, I don't think Clonorchus is endemic in the River Cam.
You're right, Joe. And I'm not sure what it says about our population that we see more ketamine cholangiopathy than we do recurrent pyogenic cholangitis. But there are so many causes of cholangiopathies, and many that I didn't cover in my talk, but it just highlights that if you've got a funny looking abnormal MRCP that don't immediately think this is PSC, there are just so many causes that can cause a cholangiopathy. And so that's why I like that term cholangiopathy to describe the abnormalities of the bile duct before you got a bit more history from the clinical team.
Talking of rarities in the UK, Ed, I would love it if someone in the chat somewhere in the world has seen a real life case of scorpion sting causing a pancreatitis.
Well, I definitely haven't, but I know that one of the major species that can cause this is in Trinidad. And so if anyone would like me to come and do some field research and perhaps watch some cricket in the Caribbean, then please let me know, because that would be my ideal job.
So moving on to more common causes of pancreatitis. I know you are both handy with EUS. How often do you pick up gallstones in the bile duct, which are occult on MRCP?
Do you want to take this one, Katy?
Oh, I don't want to sound too repetitive saying I think if you've got a good quality MRCP, then very, very rarely. I'm just thinking of some of the some things that increase our pretest probability. So dilated ducts with abnormal liver function tests, more likely to see a stone there, or unexplained pancreatitis. But often if you look back and you think, oh, that MRCP has got a lot of motion on it. Those are the cases I tend to see more stones. I don't know about you, Ed, what your experiences are.
Yeah, no, totally agree with that. I think our MRCP protocol is quite luxury in Cambridge, isn't it? In that we have both the 2D and 3D sequences. And so with that combination, it's unusual to miss anything apart from really small stones. Sometimes they are, EUS is a higher resolution technique. So occasionally you can see small stones with that, but it's not that common. I think the best predictor of whether a study is going to be positive for a bile duct stone is who's referred you the patient, and are they good at, if it comes from a trusted colleague who's really good at taking a history for biliary colic, it's going to have a stone. Even if the LFTs are normal and the bile ducts aren't dilated, if Dr. Allison says, I think this patient's got a stone in their bile ducts, they will have one.
So if you're sort of triaging or vetting requests, would you look back at MRCP, and if it's not great, get a repeat?
I guess there's the reasons that it might not be great may still be there if you repeat it. So I think EUS is not terribly invasive test. And so we've got we're lucky to have lots of lists where we can do this, but I have quite a low threshold for swapping techniques if one hasn't worked well. And we use it a lot for our pacemaker patients as well. So although you can do an MRCP in someone with a pacemaker, our resources there are quite limited in terms of the number of pacemaker slots we have. So we just put all of those patients, if it's a question you can answer with the US, we'll do it with the US at first line.
I do agree with you, Ed. I think we were also as you say, in a very luxurious position that we've got so much EUS capacity. I think there is lots that one can do to improve the MRCP quality, and I think that's also another good route. So imaging when they don't have a chest infection or a lot of ascites, thinking about using a translator if that's a problem with coordinating sort of breath holds. There's just so much that doesn't even, before you even begin to tinker with the MRCP sequences on the scanner, that you can do.
So Ed, you mentioned acute pancreatitis patients tend to be systemically unwell, usually due to SIRS rather than sepsis itself. How do you convince the surgeons and clinicians to hold tight if there's no imaging signs of infection on the scan, but their patients on ITU unwell?
That's a good question. I suppose often there aren't imaging signs of infection when a patient has an infection. So I think what we are looking for in the state of the patient to help guide decisions around drainage are, has the patient started getting better and then got worse? And I think that's a useful marker of infection. But sometimes, it doesn't necessarily show up very well in their inflammatory markers or their temperature. Sometimes it's more just it can manifest as a sort of failure to thrive. So you might have this patient with a collection who's just been sat there on the ward, not really getting any worse, but not getting any better for a long time. So I'm generally not trying to dissuade the surgeons from drainage procedures, apart from in the first week where you just think it's not going to make any difference. And I think ours they look after a lot of pancreatitis patients, so they generally don't ask for it early. And they also like it if we drain it endoscopically, because it's less work for them, because they're then unlikely to have to come back and do a surgical percutaneous necrosectomy through a drain track route. So they tend to hang on until an endoscopic drain is feasible, and then we'll do it that way. Generally, I'm not having to talk them out of drainages. In fact, I'm sort of just agreeing with them, but I'm probably lucky to work with such an enlightened bunch of surgeons.
Ed, you demonstrated the importance of making the distinction between necrotic and non-necrotic collections, with those that are necrotic, so walled off necrosis, more likely to require intervention. But how often do you find yourself draining pseudocysts, so non-necrotic collections, and what do you think some of the common indications for doing that would be?
They're actually pretty uncommon, aren't they? True non-necrotic collections, and they often resolve spontaneously. So by the time you get out to sort of 3 or 4 weeks when you might be thinking about draining them endoscopically, it's pretty uncommon to see them. So I would say not often do I get asked to drain them. Sometimes you don't know it's a non-necrotic collection for definite until you do the EUS and you see, oh, it's completely crystal clear inside. They tend to cause less problems, don't they? You get fewer complications with a non-necrotic collection, and they're less common already. So they just less frequently end up in front of you for a drain. What problems they cause, I guess fewer than a necrotic collection, but otherwise all the same sorts of things. So pain is probably the commonest thing. They're less likely to get infected, but they can do.
Can I just ask a question? Would you still use the same type of drains? You would use a hot axios for a pseudocyst, or would you just use a pigtail?
So that's a great question. We traditionally have used hot axios for everything to drain first line, and then when we take the axios out, it comes back again. We assume that they have a disrupted duct, and so in that situation we use plastic stents only, because they can be left for a long time, at least a year, potentially lifelong in elderly patients. So that's our approach. I think probably that's something that will gradually shift back to using more plastic stents, unless the price of the lambs drop considerably. So that's, I think, as more competitors enter the market, then hopefully the cost of a lambs will reduce and it will become less of a big markup to do it that way. But they're certainly very convenient to use, and so when you have a busy list, there's a very strong temptation to do it that way.
Moving back to CT guided drains, Ed, I'm a fellow trocar enthusiast, as you are, and I loved your CT drainage case where you're using the drain for the extra length, but that looked fairly close to the left kidney. Would you be using ultrasound at the same time as CT there, or just going with CT and being a brave person?
I mean, bravery is sometimes stupidity, which I'll accept. I wasn't using ultrasound for that case, and I think that's one of the things that's very hard to demonstrate, even when you're next to someone doing a drain, is the feel that you get when you're going through different tissues. The kidney is a really solid lump. So if you hit a kidney as you're advancing a trocar, or even just a needle, it does have a very different, sort of more rubbery texture than the retroperitoneal fat. So a combination of stupidity and just feel of what it feels like to go through the tissues meant that I could avoid using ultrasound. I think if you've got any uncertainty about where you are, then get as many imaging tests out as possible. So ultrasound would work very nicely for that, I think. I love a trocar just like you, Joe. And I was going to ask you about your technique. One of the things that I find can be a challenge, say if I'm doing a trocar drainage of the gallbladder on call, is that I have to make sure I've got an assistant who is comfortable with the technique and able to unscrew the sharp bit from the drain. Is that something you've had problems with, or have you got any tips of how you get around that?
The reason I love trocar is because I've learned to do it without any assistance at all. So I generally do these on my own. That's why I love them, because I can do them at bedside. I don't have to rely on people. And I have people, especially on ITU, who can do running off and go and get things for me when I've dropped something or something silly like that. So yeah, I actually do it all on my own, and that's why I love it, because it just goes in, I unscrew it, cut it tight, and I can just do it on my own. So I don't really use an assistant.
So can I ask how you do it then? So do you park the needle where you want the sharp point of the trocar where you want it, and then do you put the ultrasound probe down to then unscrew the drain and put it in?
Yeah.
Okay, I will have to
Well,
try that.
I unscrew it and then I put the probe back on to watch it for. So it's just that there's a small point where I make sure it's fixed. I just unscrew and then I put the ultrasound back on, push it
So
in.
then you've got your unscrewed trocar
Yeah.
with the drain over the top. Do you then have a quick look with the ultrasound probe and then slide the drain
Just
in and
push it
then a
off.
quick look?
Yeah.
Okay,
Just
that's really
check
cool.
where it is. Yeah. So that I just make sure, because I know it's going to go into the gallbladder and not do any harm when it's nice and soft, and then just have a nice picture at the end. Not as nice as the one you shared with me, showing it unfurling, but I'm pretty
I
happy
have an assistant.
it's going to be in the exactly. I'm pretty happy it's going to be in a nice position. So yeah, generally, and I feel it's quick and easy without an assistant. So I just try and be as efficient as possible.
Great work, guys. Without an assistant, all very impressive drains on show there. Joe, you mentioned performing these gallbladder drainages on intensive care, and a question I've had for many years is in just the couple of centres I've worked at, there seems to be a huge range of the types of patients that are referred to radiology for gallbladder drainage. I really loved your bit on the Tokyo guidelines. That's really helpful. But can you just provide an overview of sort of some of the other groups of patients that you're commonly performing these procedures on?
Yeah, so it's not always really sick patients you get. You often get those patients they've come in, they've been unwell, they've been on antibiotics, but they're not really improving after those 48 to 72 hours. But they're not really fit enough to have a hot cholecystectomy. So in those patients, we usually drain them in the department. They're fairly stable. They can become unstable afterwards if you haven't got the antibiotics right, because you stir up all the bugs. But yeah, we tend to put them in for that cohort. Another cohort is the people who've sort of perforated the gallbladder and have a nice walled off collection. So they're fairly stable. But I often just drain the collection and the gallbladder if it's still distended, let that settle down, and then you can take the other one out from usually a bioloma, infected bioloma, and then they have the gallbladder drain to manage the gallbladder from then on.
Two separate percutaneous drains into that one.
Occasionally, yeah.
Okay, yeah.
Because I used to always ring up the surgeon and say, do you want me to drain the collection or the gallbladder if it was still distended? And the answer was always, just drain everything you can see, please. And yes, we want a gallbladder drain. Okay. So I usually, if they are coming down for that, I will put a gallbladder drain in. Obviously, there are a few cases you might not do that, but I can't imagine them doing a hot gallbladder when they've got a big perforated bioloma there. That's how I tend to approach it.
If you ask surgeons how many drains would they like, the answer is always yes.
Exactly. Yeah. Can you just drain everything, please?
All of the drains.
All of the time.
So interestingly, that first cohort of patients I talked about who are basically never going to be fit for surgical intervention, going back to the EUS approach, do you think they may benefit from an EUS guided intervention to the gallbladder, which I know is, from my reading, becoming a lot more popular and gaining popularity in the management of acute cholecystitis?
Katy, you know all about this one.
I do, but you're very good at doing these. I think the evidence for the efficacy of percutaneous versus EUS guided drainage is that they're equivalent. But where EUS is slightly more superior is in terms of complications afterwards, in terms of return to hospital. And the thought behind that is that they're less likely to be displaced and required to be put back in. I think that's the only slight benefit of doing it with EUS. So Ed, in practice, I don't know what you're finding. Are you doing it after a percutaneous drain has already been attempted, or as a sort of first step?
We're quite conservative with this procedure in that there's a lot of patients that can get referred for gallbladder drainage, and although we've said we've got lots of EUS capacity, actually we probably haven't got enough to absorb all of these patients onto our lists to do. And also they're often quite sick, and so sedating your patient who's becoming hemodynamically unstable from their acute cholecystitis is not an attractive option, really. So yeah, I've been using it in patients who have already had a perc drain and dislodged it at least once. And then ideally they should have if their gallbladder's not fully distended, you might want to wait until they've actually got a drain in situ. You can then flush the drain until the gallbladder's distended enough and then drain it. But so we haven't had to use it that often. But in terms of difficulty, it's not a hugely difficult EUS drainage procedure to do, easier than a bile duct, for example. So it's certainly an option if you've got it available.
Interesting. So continue on this intervention theme and probably bringing it back full circle to PSC. Katy, what's the role of biopsy in PSC?
Great question, and I think there's been a real shift over the years as to how we've ended up where we are now, and that's because PSC affects the bile ducts in a patchy fashion. So you can biopsy a tiny bit of the liver, and that be normal, but that's probably a sort of false negative. And the MRCP is what provides a better overview as to how the liver is affected, and that's why radiology is so important to PSC, and that's why it's something I wanted to cover for this conference. Having said that, there are some instances where a hepatologist might want a liver biopsy, and in my talk I covered PSC that we can see, but then so large duct PSC, but then there's this other subset called small duct PSC, and if the symptoms or the biochemistry would suggest that might be what's going on, then that would be one indication for biopsy. And then a second is if the clinical picture isn't quite fitting and maybe you think there's a concurrent condition, for example, PSC and autoimmune overlap syndromes. That's another area where biopsy might be useful and could affect management.
I think they've come to the end, and I'd like to say thank you both for joining me for this great chat. It's been a great deep dive into the imaging and quite tricky diseases of the pancreas and the biliary tree.
Thanks, Joe. Thanks for having us. Really enjoyed it. Thank you.
Yeah, great, Joe. Thanks so much, and good to see you, Katy. Cheers.
Thank you to Joe, Katy, and Ed for recording that discussion there back at Radiopaedia 2025. It was so long ago. Now, most of that was a little too hepatobiliary for my predominantly neuroradiology and MSK brain, Gaylard. But I have jotted down a couple of little things and thoughts that I had while I was listening. How about you?
I mean, I like bile as much as the next guy, but it's never really been my thing. I did briefly reminisce during the chat there about how much I enjoyed doing procedures in the past, and specifically, procedures with pigtail catheters into hollow viscus or abscesses or something, and that was fun. I rarely do them now. I rarely do anything really other than the occasional spinal injection. Do you still do many procedures, Dixon?
Not as many as I used to. It's a bit of a love-hate thing, isn't it? You kind of you kind of think about it after you've done a procedure, it's quite satisfying. But then when you get interrupted and you need to go off and do this procedure and you're halfway through something else, it's like, oh my gosh, I got to go and do this. Yes, I'm doing less than that I used to do. Still do quite a bit of MSK and some occasional head and neck type interventions. But actually that relates to what I wrote down here, which is I think it was Ed who mentioned, that feel of going through tissue that you get with experience of doing a procedure, and how he was talking about how the kidney feels different when you go through that.
Yeah.
And I think this is absolutely something that people underestimate. It's not just about looking at the screen and putting the needle into whatever the target organ or tissue is. There's so much feel to the whole process. Like, for example, if I'm doing a shoulder hydrodilatation, I can tell when I'm entering the capsule and when I'm exiting into the joint. I know when I'm there because I can feel when I push down on the plunger that there's not very much resistance and the local anesthetic is going in nice and freely. I must be in the actual joint space itself. Yeah. I often get called into the fluoro room and trainees are halfway through a hydrodilatation or something and they're having trouble getting into the shoulder. And I walk in, I look up at the screen and you can vaguely see a shoulder there, but mainly what you can see is contrast just infiltrating through, subscapularis fibers that they've been forcing in with all their might. They've got beads of sweat as they're pumping this contrast in, hoping that it'll just somehow find the joint. So I like to teach them, feel for the capsule. You can tell when you're in it, feel the push through that kind of gives away, feel the local anesthetic freely moving in, and only at that point do I change my syringe across to the one that has the contrast in it and actually inject. And really, I take a picture with the contrast to prove it to someone else rather than necessarily to know for myself.
I think that's right. Doing things by feel is such an important part of any procedure, and it's hard to teach without having that real apprenticeship kind of model where you're standing next to the trainee, watching how they hold the syringe, talking them through, seeing where they struggle. It's not something you can do remotely across the room or retrospectively. In my previous life, as you know, and many of our listeners may know, I was a neurosurgery trainee. I didn't get very far before realizing it wasn't for me. But this idea of not being able to teach procedures over the phone brings back a particular episode that I'm sure I've bored you with before, but I don't think I've shared it with the audience here. And this was a fateful night years and years and years ago. So 20 years ago, I guess. This is just a quick interruption from Future Frank. Just wanted to let you know that I'm about to launch into a story of a complication that happened to a patient of mine from many years ago. And I want to make it absolutely clear that there's nothing intrinsically funny about complications. They occur to real people. They often have real consequences that cause sometimes long-term harm, both to the patient and I think importantly, and sometimes forgotten, also to the doctor, because there is stress and trauma and guilt and anxiety that stems from the harm that we sometimes inadvertently do to patients. I tell this story because I think there are some important messages in there about mentorship or the lack thereof, about how one responds to these events and how one copes with complications by talking to each other and sharing them and not pretending that they don't exist. But rest assured that I take all of this very seriously and still feel guilt and remorse for every complication that I've had over the years. Okay, back to the show. There was a little old lady, one of these little Anglo-Saxon ladies who won't complain about anything, who'd had a fall and had a type 2 dens fracture. And she was 80 or 90 or 100 or something. And so no one wanted to do an ORIF of a transoral screw or whatever else had to be done. So I was told, just go put on a halo brace. I'd seen one done. I'd helped do one. This was the middle of the night. And in fact, Natalie was my resident at the time. So I said, okay, let's go do it. Let's bond over putting a halo brace together. And I would never have admitted that I didn't feel comfortable doing it. Not only because you've got that surgical mentality of can do and you're just going to crack on and do it, but also because my girlfriend was there as my resident. And so I had to show that I was a confident, competent man. And so I took the halo brace and I spoke to this lady and put the local in. And all you do is you shave a little bit of the hair, and you put some betadine ointment on, you put a little bit of local in the scalp, and then you screw this big long screw through the scalp, directly through the scalp into bone, using a screwdriver that has a torque setting. And the idea is that you crank it until you get to, I can't remember the setting, like say 20 or something, and then you know that it's tight enough.
Yep.
And so I started doing that, put all of them, you touch the skin and go just to the edge of the bone, go round. And then I started tightening and I'd tighten it, go 1, 4, 5, 8, and then we'd drop back down to 1. And I'd be like, all right. I went to the other screw, did the same thing. Went around a few times. Then I called my boss, who wasn't there, right? And he knew I'd never put one in. And I said, look, this is what's happening. Every time I tighten, the pressure goes up, but then it drops back down. I don't know. Am I doing something wrong? And he's like, no. It's all fine. Just keep going. It's like, okay, I'll keep going. So I kept going. And I ended up running out of screw on all 4 screws. They were all flush with the halo brace. And I was looking at this little old lady who was staring at me with these big trusting eyes. And I'm trying to picture how thick her scalp has to be and how long the screws are. And I'm like, I don't think her scalp is this thick. So we got a CT scan, and all 4 screws had gone through bone, through subarachnoid space, and into brain. Some of them by quite a distance, all under local anesthetic. And she was fine. I mean, fine. She had a few hemorrhagic contusions, well, 4 of them to be exact.
Oh, gosh.
And I took photocopies of all the notes, and I didn't sleep that night. I was sure she was going to die, and I was sure I was going to get sued. And she was fine. Everyone was fine. Everything turned out fine. There was an uncomfortable open disclosure discussion with her and her family the next day. But it was a perfect example of just, you can't teach this over the phone. If you haven't done this, the words that we use to communicate physical actions don't really capture the whole experience. You need to be there. But I still have the CT on a sheet of film in my office on a light box. And whenever one of my trainees has a bad complication and they're clearly rattled, I say, I know you feel bad. I know you feel very bad, but come, I want to show you
Have
something.
a look at this.
And I tell them the
Exhibit
story. And, it could be worse.
The other thing I've written down here, Gaylard, was something that Katy said, and that was along the lines of, I don't know why I teach things I find the trickiest, when she was talking about her PSC lecture or one aspect to it. I found that comment quite interesting. In this context, she's talking about a difficult area requiring some clinical experience and nuance, which I think is absolutely perfect fodder for a lecture, particularly those grey zone kind of cases. But it made me also think about those lectures that I hate the most, which is similar to this, but not quite this, which is when someone is teaching an advanced thing purely to make themselves seem amazing and clever. A technique that they actually don't use themselves. They've never applied in real life. They've just looked it up and gone, oh, that looks like a good advanced topic. I'll do some slides on that and then present it. They've probably learnt it just for that talk, and they have absolutely no real practical knowledge.
The best lectures are those that acknowledge that some things are hard and grey and give you ways of muddling your way through it. Sometimes it's giving you permission to say, I don't know. I know there are folk in my department that I show cases that I'm unsure about. And what I want out of them is not a simple answer. Someone like Peter Mitchell saying, oh, I don't know. You see this sometimes, but I'm not sure what it means. I don't think it's anything. I don't know how I would report it. That's okay. It feels real and not fake, as opposed to those lectures where you come out of the lecture thinking, oh, this is great. This is so simple. And then the very first case that you see just falls apart because those cases don't exist. It's the equivalent of Instagram. You have your own messy life. You have bad days. Your hair looks terrible. You've got a cold. You've got hay fever. You've had a yelling match with your kid. You and your spouse aren't talking, whatever. And you go onto Instagram and all you see is a constant stream of all of the people that having perfect, shiny, simple lives. And lectures are a bit like that. It's like, oh, look at this perfect example of this entity, and this is what it looks like. But you never actually see that in real life. And so I think lectures do need to embrace the dirtiness and greyness and smudginess of real life and give you skills to work your way through that, not identify the classic appearance of a classic presentation.
Yeah, I was actually thinking about this the other day because I had a reading through the feedback comments on my chest x-ray science course, and one person wrote one thing they would love to see added to the course would be just a section of really crappy chest x-rays where just the signs aren't clear, because a lot of classic examples are used in there, and I did think, it is a good idea. There should be this kind of section at the end where it's like, I've deliberately chosen these chest x-rays because they're not very good quality, but the signs kind of are there, and you need to be able to look through the mess to recognize these things to make a nice diagnosis.
One thing that makes me think of is Rob Gibson, who is a consultant in my department and taught me an amazing hepatobiliary and particularly in ultrasound. And I remember him, I think I must have been in first year going through ultrasound. And he said, when patients are difficult to scan, that's when you spend longer scanning, not less time.
Mm.
And it feels obvious, but actually when you see your reaction to, say, a CT scan where the patient has moved, your gut reaction is, oh, they've moved. This is all too hard. I'm just going to say movement degraded and move on. But his point was actually, no, when things are hard, when they're not holding their breath, when there's bowel gas in the way, when they're fat, when whatever, that's where you slow down and take longer because it's harder, but you still need to get the answer, and you can still get the answer. It just takes a bit more effort. And I think that's what you're getting at with the terrible chest x-ray. It's really easy to dismiss it as poorly rotated, poor inspiratory, whatever. But often it's just a bit harder than if it was perfect.
Little jiggling Eric I heard in the background there, Gaylard.
Well, he's at his most vulnerable stage now because his fur is at just the right length that if we ever decide to taxidermy him, this is the length at which we would do it.
This is perfect.
Yeah.
Now, is there anything else you wanted to bring up from this main discussion?
Well, there's one thing, and that is with all that talk about scorpions, it made me think of something that I read on Wikipedia recently as I was wasting time random link surfing. And you and I know that Australia has many of the most venomous animals on the planet. We have the taipan snake. I think that's considered the most venomous snake in the world. The box jellyfish, which is everyone's favorite. Blue-ringed octopus, the funnel-web spiders, and all of that. And everyone's favorite, the infamous drop bears, which you have to be very careful of this time of year.
Very, very careful, yeah.
But I have a question for you, Dixon. What are the deadliest animals to humans in the world? Not in Australia, but in the world.
They're probably other humans, I guess. Or is it cattle? I've heard that kind of bandied around before. I think, like farming kind of injuries from cattle stomping on you.
So you're close. The Wikipedia article, and I have some reservations about this, and I'm sure we'll go into it, but you'll kick yourself. The most, by quite a margin here, is mosquitoes. And the numbers vary, but in the table that they've got, they say about 1 million humans a year. Then humans kill other humans about 500,000 a year. I think they use the word murder, so I don't think that includes wars because that would go up quite a bit, up and down, depending on the year that you're in. And then there's a massive drop below that. You've got snakes are next, and then you've got dogs. And then, here come the good ones, freshwater snails, assassin bugs, which I'd never heard of, but sound awesome, and tsetse flies and so on. And then after a few more, scorpions reach there. And not one of those are our Australian ones. Why? Because there's only 25 million Australians. So there's not enough of us die to get into this list. But I looked up assassin bugs because that does sound cool. And I pictured some little guy, wielding a machete or something.
Yeah.
And instead, no, they're responsible for transmission of trypanosoma that causes Chagas disease. So I don't know if that counts because it's not the assassin bug that kills you. The assassin bug only kills you by giving you this infection.
Yeah.
But then by that logic, mosquitoes don't count either because most of them kill you through malaria. So
that's a very sneaky assassin who murders you indirectly.
That's very sneaky because then with that logic, maybe you could say that cattle contribute to greenhouse warming. And therefore,
exactly. How indirect do you make it?
Yeah.
I guess the other way of flipping it around is going, would you rather be bitten by a mosquito or by a snake? And I would far prefer to be bitten by a mosquito, right? Because the individual bite, the probability of you dying is far higher from the snake.
And you can treat malaria.
Anyway, speaking of being bitten, it just reminds me because I saw this movie recently. Have you seen the movie Sinners?
Yes, very good. But I think I'm a bit dim, and this is a confession, I guess, is that I watched the whole movie.
Yeah.
The whole movie.
Yeah.
And did not realize that the two main characters were played by the same actor until I watched a review at the end. And there's this big thing, all the CG to make them face replace and all of that.
Yeah, the twins. I got almost all the way through before I was like, hang on, that's the same actor. I don't know why you would do that because doesn't it just add expense to the whole process? I guess maybe the actors are very expensive and their CGI is cheaper. I don't know. It just seemed like
it didn't feel necessary to the story.
Yeah. But it's one of those movies where I don't think we should give any spoilers to it because I went into it Belinda just put it on, and I had never really, I think I've heard of the name of it, but I had no idea as to what it was about. And it doesn't go where you expect it to go.
No,
And it's quite a fun ride. So if you haven't seen it, it's
Yeah.
quite a good one.
And we're going to catch a movie in a day or two, just a Frank and Dixon matinee and lunch day.
That's right. What movie are we going to?
We're going to see Begonia, because I think
Begonia.
both of us have a bit of a crush on
Yeah.
Emma Stone, is it?
And it's about an assassin bug, I'm pretty sure.
I think it's an assassin bug.
All right, I think it might be time for us to wrap this episode up, Gaylord. How can people get in contact with us?
You can email us at podcast@radiopaedia.org with any ideas and feedback. And you can also join the Radiopaedia community chat by visiting radiopaedia.org community.
Yes, where spam is not allowed.
Oh my God. First time. Even there we have someone who tried to sell us crypto.
Good stuff.
Unbelievable. Never ends. It's a constant fight. It's like mosquitoes.
Got to swat them away, swatting away the spam. But you can write to us just like this person who wrote about our last episode, Gaylord. It's Jim in the UK. He writes, I hope I'm not the 100th person to mention this, but I'm told one of the tricks to ensuring clear, non-cloudy ice is to boil the water first for a minute or so, then allow this water to cool before using it to fill the ice trays. Thanks for the episode. It clarified a lot about iterative reconstruction and photon cleaning. CT. Cheers, Jim in the UK.
Did you see what he did there? He said it clarified a lot.
Yeah.
That was pretty clever. Well done, Jim. So the boiling, I'm not going to go on a rant here, but I'm still so far from having clear ice. This is why there are companies that sell you a block of, like, for one drink at $2 or $3 of clear ice, because it's not actually that easy to create a large chunk of clear ice at home. I think the boiling might help, but it hasn't helped that much. I think the speed of cooling is actually a factor that now I'm investigating. I'll at some point have to give you an update. It's been
I wonder if the boiling depends on what quality of water you're beginning with, and maybe the Melbourne water, it doesn't have much of an extra benefit to changing.
Maybe. I think if the speed of cooling might be that when you put in boiling water, it actually end up putting it in a bit hotter, and so it slows you down a bit more, because fast cooling, definitely very bad for clear ice. It's so much more complicated than radiology.
All right, how about this email from a listener then? So it says, this is from Olna, and it is, Dear Frank and Andrew, I've been a fan of your podcast for quite some time. I'm a student studying medical imaging and radiation therapy in the Netherlands. I'm struggling to decide if studying to become a radiographer is the right choice between radiography and radiology. I am concerned that the job won't bring me enough satisfaction, and radiology would be the better course of action. Having said that, I was wondering if you could invite a radiographer on the podcast and compare the two jobs. Does the job bring enough satisfaction? Is one harder than the other? Why did you choose this route? And are you happy with the decision? Thank you very much for your time. Looking forward to hearing from you. Stay rad. Well, I think it would be very easy, wouldn't it, to invite Murph onto the podcast, Gaylord, to have a chat about radiographer versus radiologist. It's good clickbait too, isn't it? What do they do? I'm pretty sure radiographers just push buttons, but we can ask him and see if there's more to it than that.
I believe, at least for CT, that you also have to occasionally say breathe in and hold your breath. But it's probably automated by now. There's probably a button for that as well.
It could be.
My guess.
But you see, we don't know. So we should get Murph onto the podcast. No, we're being a bit silly, but it is a good topic to talk through, because I think there's misconceptions about what radiologists do, but there's also misconceptions about what radiographers do. And both of them are very rewarding careers and have quite different aspects to them. So I think it'd be good to get someone like Murph in and have a chat with him.
Did I tell you what my father said to me when I told him I wasn't going to be a brain surgeon? Have I ever told you that?
I think you have, but I can't remember exactly.
He was quite invested in having a son that was going to be a brain surgeon. And when I told him that I wasn't going to do that, he took it quite hard. And he said, well, so what are you going to do? And I said, I'm going to be a radiologist. And he said, so you're going to take x-rays for a living? And I said, no, Dad, no, that's a radiographer. The radiographers take the x-rays. The radiologists interpret the x-rays. And he looked at me and he said, "So you're not even going to take x-rays for a living?"
Perfect.
Yeah. That's
he's a
all you
good
need to
man.
know. Is he?
I'll read this next. And if you want to help support Radiopaedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle income countries. And as we said in the intro, December is our supporter drive. Perfect time to become a supporter. Sign up for annual billing and you'll go in the chance to win access to the conference as well. And what else can people do to help us out, Frank?
Well, other than becoming a supporter, you can help out by leaving a 5-star review in the podcast app of your choosing, and, a review with words as well as stars. Let us know.
And we'll catch you all again sometime soon in the reading room with a Begonia update.
Oh, yes, Begonia review.
One of Frank's famous movie reviews.
Stay rad, everyone. Stay rad.
Stay rad. And have a very good Christmas, everybody.
Yes,
and we'll
absolutely.
see you all in the new year for another episode. Bye.